Well, again, my name is Troy Vandiver, Vice President here at BrainCool in the United States. I also work with our international partners and company to try to raise awareness about temperature management worldwide. That's our goal. We're very excited to have the speakers we have today. They're all renowned speakers, key opinion leaders in the topic of temperature management. We're very grateful to them for taking the time to be with us today. We anticipate more and more folks will join as this event continues throughout the night, and hopefully as we put more events on in the future as well. With that, let me introduce just quickly the schedule. We'll have three speakers, Dr. Stephan Mayer, Dr. Jennifer Frontera, and Dr. Kiwon Lee. We're going to start off with Dr. Mayer. And by way of introduction, Dr. Stephan Mayer is a professor of neurology and neurosurgery at New York Medical College and the director of neurocritical care and emergency neurology services at Westchester Medical Health, Westchester Medical Center Health Network. He's a leader in the field of neurological intensive care. Dr. Mayer is a pioneer in utilizing TTM across an array of patient types. He's the author of more than 230 original research articles, 180 review articles, 340 abstracts, and 7 books. Those numbers are probably more by now. I've had this intro for some time. Without further ado, Dr. Mayer, the time is yours. It looks like you're just on mute still.
So thank you very much, everyone. Thank you, Troy, for the opportunity. Thank you, Dr. Frontera and Dr. Lee, for joining us. And here we go. Okay, can everyone hear me? Can I get a thumbs up? All right, so for 20 minutes, I'm going to be talking about how to cool ICU management and shiver control. And we're going to hear a little bit later about why we want to cool patients from Dr. Lee, but suffice to say, we've understood the therapeutic power of lowering body temperature to attain neuroprotection for a very long time. But historically, it's important to recognize that therapeutic temperature modulation, or TTM as we call it today, is still relatively new. It really came on the scene in the early 2000s. Before that, it was really research when I started doing it in my career. But it was really the cardiac arrest indication that made it an imperative. So we had lots and lots of nurses and doctors in intensive care units who had never really intentionally cooled human beings before that had to learn. And as we got better technology to cool patients, there were a lot of lessons that we learned along the way about how to do it right. And that's what I'm going to be talking to you about today, how to do it right. The concept here, though, is that as intensivists, we manipulate physiology. And we think nothing every day of manipulating hemodynamic parameters, ventilatory parameters, everything else. And we now have the tools or devices that can allow us to precisely regulate core and brain temperature. So as intensivists, we're really obliged to identify and maintain body temperature at an optimal level for patients with acute brain injury, because we've known for a long time that lower temperatures are better in the setting of ischemic injury, injury from hemorrhage, whether the problems are leading to increased intracranial pressure, brain edema from blood-brain barrier disruption, and the like. In terms of how we cool people, these are the 4 main modes of heat or energy transfer. And the main mechanism that we use is conduction, right? And the model for that is cold water immersion. And so we can accomplish that with surface cooling systems I'll be showing you shortly. We can also do heat conduction intravascularly with so-called endovascular heat exchange catheters. So in the old days, our technology was pretty primitive. It was really bathtubs full of ice. These are photographs from the operating room. In the 1940s and 50s, it really was only in the operating room where there were these types of techniques, mostly for cardiac surgery, somewhat neurosurgery. Wasn't really a thing in the ICU other than opening open the windows on a December night in an ICU and getting the whole room cold. We didn't really have great technologies to cool brain and body temperature. Quite early on, there were questions about, can you cool the brain locally? Can you put on a cooling helmet? Can you do nasopharyngeal cooling and the like? And in this classic study that's already almost 40 years old now, a number of different of these local approaches towards cooling the brain were compared and evaluated. And investigators concluded that really the only way to really cool the brain is to cool the whole body. And the reason for that is that if you try to cool the head, you're effectively counter-circulating the cold head with all the warm blood from the rest of the body. This is the first human being that I ever cooled. This was a patient in 1997 enrolled in an IRB. He had a middle cerebral artery infarct. And the only tools that we had in those days were what I called your grandmom's cooling blankets, right? We're all familiar with these different devices with stiff plastic blankets that you would lay on top of a patient, maybe under. In this patient, we had them under and below. But there were problems with these devices, and these have been shown in fever control studies, mainly that there's a lot of air in between the cold pads and the skin. And there's often pajamas and sheets and blankets between the cold pads and the skin. So this is not a good way to attain good heat conduction. It's not a good way to attain good energy transfer. Other surface cooling systems now apply pads directly to the skin. This is a system that you may be familiar with, where the pads are lined with a hydrogel. This is a system, this is the BrainCool system, where these are pads that are non-adhesive but still maintain excellent contact with the skin. The cooling cap can be applied here as an adjunct, but like I'm saying, it's not really going to work alone. You need to apply the cool pads for a surface cooling system to the thorax and often to the lower extremities, the thighs as well. There are also systems that use endovascular heat exchange catheters. So this is a system which effectively is a triple lumen catheter, but with an inflow of saline, which circulates through a closed loop, and then it leaves here. And you don't see these little balloons, but they fill full of the saline. They pulsate to some extent. There's local turbulence, and that effectively cools the blood in the inferior vena cava, returning into the heart. So it's internal heat conduction, so to speak. And because you're removing heat, of course, the closed loop saline that's leaving the catheter is warmer than the inflowing water. And that's exactly what happens with the surface cooling systems as well. It's closed circulation of cooled water. And when the water leaves the blanket, it's warmer, having removed heat, than it was when it was flowing in. And just a few more examples of the types of devices we have at the bedside to measure core body temperature. In terms of measuring core body temperature in the ICU, there are a number of ways to do it. My favorite way is to insert a Foley catheter with a thermistor. It's highly accurate measurement of core body temperature. Other alternatives, rectal catheters, well, they're kind of messy. Pulmonary artery catheters, theoretically, but nobody really uses them anymore. The esophageal probes can be dropped in intubated patients, and that's good. Other types of systems are not recommended. Axillary temperature is not going to be accurate enough to panic. The other kind of surface sensors are not going to be accurate enough. So you really want to be measuring an internal core body temperature with a bladder or esophageal probe. There is another way to attain cooling, which is the refrigerated saline trick. And this is the main study that put this on the map. So what you do here is you basically take 2 liters of normal saline, you leave them in refrigerators in your ICU at about 4 degrees centigrade, so cold but above freezing. And then for your average person, you want to give about 30 mLs per kilogram, right? So that would be about around 2 liters for a 70 kilogram person. And you basically run that fluid in maybe 500 mLs an hour. You can run it even faster if you think the patient can tolerate the volume. And what you see here is that with this protocol here in a large cohort of a variety of different forms of brain injury, you see a nice temperature drop. This bar is at 1 hour. It's not labeled, from about 37 down to 34.5. And then with that second liter, you can get down to 33. So this is a way to so-called kickstart the cooling process. It's very nice for emergency departments if you're not resourced in the ER with these fancier servo control cooling systems. You can just start hanging the saline while you're waiting to get the patient up into an ICU bed. So many centers that cool cardiac arrest patients are going to use this type of a launch system for lowering core body temperature. Now, at this juncture, I think it's important to mention the old adage that every medicine has a little bit of poison in it. And that also is true of TTM, or lowering core body temperature, particularly when we're lowering temperature from core to a hypothermic level. As we know, the conventional target for mild to moderate hypothermia is down to 33 degrees centigrade. And we know that as we do that, we can see various side effects, and they fall into 4 buckets. First is cardiovascular. Heart rate can slow down, myocardial contractility can slow down. And it's thought that if you drop below 30 into the moderate hypothermia level, you can even trigger ventricular ectomy and arrhythmias. We know that as you lower body temperature, the blood can become thinner. There's platelet function becomes less robust, and you can actually measure prolongation of the PT, PTT, et cetera. Although we don't feel that these effects on coagulation are usually clinically significant or important. Much more important is the immunosuppression, that macrophage and neutrophil function is reduced, and we know that there is an immunosuppressive effect. In fact, the majority of randomized controlled trials for various indications, such as cardiac arrest, stroke, and TBI, that have looked at lowering body temperature to 33 have found higher rates of ICU-acquired infections, in particular pneumonia, when we cool. So this is something to be very careful about, to be cognizant of, to maintain best practices. And in a way, it's really a reason why we want to try and use our TTM wisely and not for very long periods of time. And then the 4th category is this general bucket of metabolic derangements. This includes hypokalemia, which you're going to see uniformly, hyperglycemia due to insulin receptor resistance, which you will see uniformly. Other types of side effects are not seen uniformly, but you can develop various types of cold diuresis and ileus, et cetera. And then the other thing which you're going to see uniformly is shivering. And I'm going to talk a lot about shivering in the rest of the talk, because it is so important to understand the pathophysiology of shivering and know how to manage it correctly so that you get the most out of your TTM intervention. And this goes both for fever control indications, which we'll be hearing about later, as well as TTM to induce levels of hypothermia, be it 33, 36 degrees centigrade, or anywhere in between. So what is shivering? Shivering is a physiological reflex. It's an involuntary reflex that occurs when the body feels a need to produce heat to maintain body temperature at the brain's physiologic set point. The primary center for shivering, the driving center, is in the posterior hypothalamus. It's a brain autonomic reflex. And it's important that to understand shivering. Now, the story with shivering is this. You heard me talk before about your grandmom's old-fashioned cooling blankets. All those years that we were using those blankets and putting them on febrile patients, we never saw shivering. The reason is this: they actually didn't work. So you're going to see shivering when you use a cooling technology that works. Anytime you pull the core body temperature down below what the brain wants to be, you're going to see shivering. That is the case if the brain wants to be febrile at 39 and you're treating the fever and pulling the core body temperature to a set temperature that you want to get of 37, the body and brain will fight with shivering. Similarly, if the core body temperature wants to be 37 and you're pulling the core body temperature down by removing that heat to try to get to a target temperature 33, you're going to see shivering. Shivering, folks, is the enemy. Shivering is fighting everything that you're trying to do in TTM, right? It's hurting the patient. It's painful and uncomfortable. And shivering, in addition to just fighting what you're trying to do, causes stress. It causes increased cardiovascular and sympathetic stress. It can double or triple the body's metabolic rate. And shivering actually increases the brain's metabolic rate. The brain's need for glucose and oxygen goes up when the patient is shivering because it's got to activate and move all those skeletal muscles. This can lead to mismatch of the supply of O2 and glucose and the demand. It can aggravate ischemic injury and various forms of oxidative stress in the brain. Hence, the detection and control of shivering is the single most important ICU bedside activity when TTM is applied. So here's again how the shivering works is shown here, right? When you heat up, right, you start to sweat. When you cool, you begin to vasoconstrict, you shunt blood from your fingers and toes, and then at a little below 36, the body begins to shiver. Shivering is fundamentally paroxysmal. It comes in bursts. And interestingly, shivering is a top-down phenomenon. It uniformly begins in the masseters, head and neck. And when it's more severe, it also involves the uppers. And when it's more severe, it then involves the lowers as well. So you have whole body paroxysmal shivering. This is some work that I did from my days at Columbia, showing the amount of brain tissue hypoxia in critically ill patients when they're normothermic. There's more brain tissue hypoxia when they're febrile. And then before we knew what we were doing with how to defeat the shiver reflex, when we were trying to treat the fevers, we were causing even more brain tissue hypoxia. And this observation was largely the impetus for developing a protocol I'm going to show you, which is the correct way to defeat shivering. It's also true that cold brains actually shiver less, a fascinating thing if you think about it. So the band, the body temperature window where the shivering is most severe is between 34 and 36 degrees. If you cool people down to 33, the brain will actually shiver less. So here are the take-home messages for how to do it right. Measure shivering using the bedside shivering assessment scale. Use non-sedating strategies first and paralyze as a last resort. So this is a simple scale, the BSAS, that allows you as a nurse or as a clinician to quantify shivering. 0, no shivering. 1, mild shivering, basically confined to the masseters, head and neck. 2 is when it also involves the chest, pecs, and uppers. And 3 is when you see visible shaking of the jaw, arms, and legs. And the bottom line is that you see here on this slide how the hypermetabolic activity drastically increases to up to 2.5 times normal if the BSAS score is 3. So 2 and 3 are basically no-nos. When you do the BSAS hourly, if you see visible shaking of the uppers or the lowers, you have to escalate your anti-shivering intervention, which I'm going to show you next. And this is just some related work showing, again, that this is the BSAS validation study here, showing these increases in all forms of types of metabolic expenditure. And also note here that we saw that lower MAG levels were associated with more shivering. And we're going to get to MAG in a minute. This is the reference for the BSAS, and we're going to try to, we'll share this reference through the chat. How do you control shivering? There are a lot of different drugs that you potentially may have anti-shivering activity. For cardiac arrest, it's really more of like an induction. I sedate up front and I go right in, usually with fentanyl or propofol, and then that's usually enough. You begin the cooling, you're going for 36 or 33. And then what I do is if the temperature's not dropping quickly and I think they're shivering, I may give a one-time dose of a neuromuscular blocking agent. For other forms of sustained shivering, for TTM, though, I'm going to show you the Columbia Anti-Shivering Protocol. This is simply just some work showing the physiologic studies that have validated the opioids meperidine, Presidex, and propofol as the best shivering agents. Shown here, lowering the threshold at which the shivering, lowering the body temperature threshold at which the shivering occurs. Right? And this is a slide here, I'm running out of time, but showing by giving fentanyl boluses to this TTM patient, right? You see the body temperature going up, the patient shivering, the water temperature is colder. We push the fentanyl 100 mics, bang, body temperature goes back down to target. The water temperature doesn't have to be as cold and warms up again because we defeated the shivering. So we're making the machine not work as hard, and we're relieving stress from the patient. Right? And then problems with paralysis, we're going to kind of move beyond that, but it's basically your last step. So here's the final take-home slide. For ICP control, if you're looking for sustained ICP control over a period of days or fever control, standing acetaminophen for fever control, and buspirone 30 milligrams every 8 hours. Buspirone, an anxiolytic, happens to have some anti-shiver effects that are synergistic with the other agents. Right. Next step is skin counterwarming with a bear hugger and a magnesium infusion. What is skin counterwarming? Well, we're blowing warm air on the skin. That warm air is not enough to actually change the core body temperature. Instead, you're sending inputs through skin sensory receptors into the brain, making the brain feel warm. In effect, you're tricking the brain into thinking the body's warmer than it really is. And you can get visible reduction in shivering simply by warming exposed skin with a bear hugger set to 42 degrees centigrade. And you can use a magnesium drip as well. About half of patients will have the shivering under control in the BSAS with this combination of MAG, skin counterwarming, and buspirone. Half of them may need some additional pharmacotherapy. My recommendation is the first line agent to add on, in addition, is Presidex or dexmedetomidine. Alpha-2 receptor agonist. It's excellent for suppressing that outflow coming out of the brain that drives the shivering. And if that alone is not able to do it, because the quality of sedation is less as well with dexmedetomidine. And then if you have to add something on top of that, if the shivering's really bad, often in storming kinds of patients, TBI patients, more often males, pick your poison, right? Fentanyl, meperidine, or propofol. So this is a bear hugger. If you're not familiar with what it looks like, it's a big paper blanket that blows warm air. And this is basically the data here showing, validating skin counterwarming, right? You see here with the patients that are already shivering, we removed the bear hugger and simply 30 minutes later repeated an energy assessment using calorimetry, and we saw massive increases in O2 consumption, hypermetabolic index, resting energy expenditure, simply by putting a bear hugger on and off a shivering patient. And here's the reference for the Columbia Anti-Shivering Protocol. We'll share that in the chat later on tonight as well. So these are the bottom line messages that I have. I think I'm just about close to 20 minutes. And with that, I want to just thank the organizers again, and happy to take a question or two. Thank you very much.
Thank you, Dr. Mayer. Really appreciate that. We do have a couple of questions here that are in the chat. Looks like one of those is, what is the impact to the patient if the patient temperature is not controlled with precision?
What is the impact if the body temperature is not controlled with precision? That's a really excellent question. Well, you can think of it as an undershoot problem. So you want to get the temperature down, let's say cardiac arrest to 33, right? If you're not getting down there, let's say somebody says to you, they go to me, say, I put this device on and I can't get them to go, right? We set it for 33 and the guy's just hanging out there at 34.5. I can't get him down. My first thought always is, right? I bet I know the problem. He's shivering, and you're not defeating the shiver reflex. And so you lose on all counts. You're not getting the level of neuroprotection you want, right? You're making the machine work harder and less effectively, and you're stressing out the patient. So you run up the protocol, bear hugger, mag drip, push the mag level, push the Presidex, and give IV pushes of fentanyl and propofol. Give IV pushes. There's an urgency to correcting shivering. Let's talk about the other hand, overshoot. Let's say that you set the device and you wanted 33. Uh-oh, it's going down to 32 or 31.5. With our modern technologies, quite honestly, that happens very rarely. 2, if it does happen, what it would make me think is that the patient's really, really sick. The brain is super damaged and in effect poikilothermic, right? We as mammals, our body's set, the enzymes are going to work best at normal body temperature 37, and our body temperature is maintained very regulated very closely, right? Poikilotherms, their body temperature just varies with what they're exposed to in the ambient temperature. If your patient's poikilothermic, they probably have a very poor prognosis.
Oh, excellent. Thank you. There are others, which we'll put your email up in the chat also, if it's okay, Dr. Stephan Mayer.
Sure.
And some of those questions can come direct to you as well. For those also joining us, this is recorded. Some of those that have registered will be watching this again and again, as it's extremely useful and educational. So thank you for that. We are going to introduce.
We actually have time for a couple of questions. If you want to,
yeah, I do have another one. Then I'll go ahead.
Yeah, we're ahead of schedule.
Oh,
Dr. Mayer did a great job, and we just didn't ask us that many questions. I know you have more questions.
How many minutes was I, Robbie?
You were 21. Good job. Nailed it.
Phenomenal. Okay, yeah, it looks like we have another one. Does AHA or ILCOR, et cetera, offer suggestions regarding the use of advanced systems or TTM systems with an internal feedback loop? You mentioned some of the feedback loop in the beginning.
You know, I'm not aware that they're making recommendations about specific devices or products, but I'm going to share my thoughts, right? Because it's my talk. All right.
That's right.
Just trying to get Jennifer to smile. You basically, the modern technology uses these feedback loops. And right, as you get closer to your core body temperature, the water temperature actually fluctuates and varies and warms up. So you stay right on the temperature that you dial in that you want. When you look at that data over time, it's really cool because it looks like a very low amplitude sine wave. The core body temperature, just like 33.1, 33.0, right? 32.9, 33.1. That's exactly what it looks like. They're very, very good. I think that for the most part, it's important to use that kind of technology. Now, what you don't want to use is your mom and dad or your grandma's old-fashioned cooling blankets, right? How do they work, right? Right? Those are the stiff plastic blankets that you use to make you to treat fever, right? You put them on the patient. The water temperature does not fluctuate or vary, right, in a closed loop. It stays 4 degrees centigrade in varying. Right? And why is that? Because it doesn't work, right? So it works at maximum capacity with 4-degree water temperature. It doesn't, right? And it never would need to go up anyway because they don't really effectively get your patient to where you want to be. So as long as you're using a device where you're monitoring internal core body temperature, again, using bladder or esophageal, feeding that into the device, that's what you want to be doing. So that would be my advice for units or doctors or nurses that are using this kind of technology. And it goes also, if you're serious about fever control, you need to be using these types of devices as opposed to the older technology from the 1960s.
Great. And then maybe just a quick follow-up to that one. If a patient presents with fever, what does your fever tree look like? What's your first line of defense in treating that patient?
That's a great question. I'm really glad that we're talking about this. Obviously, we start with antipyretics. For me, it is the kind of patient where I say to myself, I'm worried this patient has temperature modifiable brain injury. And I know what these guys look like. They cook, they heat up, and they can be like this for hours and hours and days and days and days. And my hunch is that this is bad for the brain. I know it's bad for level of consciousness, and I think it's bad for the eventual amount of brain damage. So usually these are the poor grade subarachnoid hemorrhages and the really bad intracerebral hemorrhages of the IVH. And there's probably a whole potpourri of other less common ones, but those really seem to be, I would also say a febrile malignant MCA, even after a hemicraniectomy would be another type. And my attitude is I have a zero tolerance for high sustained fevers in my acutely brain injured patients. I put them on normothermic protocols. And so that's basically how it works. So if it doesn't go down on its own early, and if the antipyretics are not doing the trick, and the guy's been up above, 38.5, 39 for several hours, after about 4 hours of that, I'm done. And we're going to do, proper TTM.
Excellent. Thanks again, Dr. Mayer. Very, very good.
Do the other speakers have any comments they want to make, thoughts or anything they want to share before we go on to the next talk? Jennifer, Kiwon?
Yeah, I mean, one thing is that sometimes we find ourselves in a difficult situation if we want to induce normothermia, but maybe the patient's not intubated and we want to spare them the sedation that would be required because of shivering. And I think that's an arena where we don't have enough data to understand the risks and benefits of keeping somebody normothermic, but heavily sedated, for example, rather than the converse of letting them be febrile, but getting them off of some of the sedation. So, I don't know, Stephan or Kiwon, if you have any comments about how you handle those conundrums.
Well, I'm just going to say that's why we developed that anti-shiver protocol, to emphasize the non-pharmacologic interventions first. Because I think you raised an excellent point, Jen. And the thinking is, if I don't want to intubate somebody just to do the TTM for fever control, right? So what I would say is let's try the bear hugger, the MAG, the buspirone, a touch of dexmedetomidine, and hopefully that'll do the trick. Occasionally, there will be situations where somebody shivers so severely that you figure I got to paralyze them, or maybe we should not do the TTM. And I had somebody just last month who was kind of like that. Don't know why he was so jacked up, but he was like hyperreflexic, lot of dystonic, dystonic posturing and stuff. And we ended up paralyzing him to do it anyway. But, like I said, that's always the last resort. What about you, Kiwon? Any comment?
I agree with everything. I think that Jen raises an excellent point. Just to reiterate her question or her comment is that if your patient is not intubated, that TTM may lead to shivering. And if you have to sedate them to offset the deleterious effects or potential harmful effects of shivering, then should you intubate? I mean, what do you do? So my comment is that if patient who you're considering TTM for is not intubated, well, what kind of brain injury is that? Chances are, what type of brain injury is a person who is not even intubated? Well, I would argue that probably not the most horrible injury, right? If it's really terrible brain injury, patient should be intubated because you don't have consciousness, you can't protect the airway, you're post-cardiac arrest, you have grade 5 subarach, they're all intubated. Therefore, if patient is not intubated and you're considering TTM, you're worried about shivering and you don't really want to intubate, well, think about what benefit you're going to get by doing hypothermia or lowering the body temperature, etc. That's just a little side comment there.
Mm-hmm.
Excellent. Very good. Thank you. Appreciate that. We're going to move on here, keep this party going. Our next speaker, Dr. Jennifer Frontera, is a professor of neurology and neurocritical care and stroke at NYU Langone Hospital and the NYU School of Medicine. She's published over 130 peer-reviewed papers and abstracts, is an author and editor of Decision Making and Neurocritical Care, and appeared on NBC Nightly News, CBS New York, and National Geographic as a content expert. And no doubt there's much more, but that's what we're limiting this to. Dr. Frontera, we're excited to hear from you. Please go ahead.
Thanks so much, Troy. I'm just going to share my screen. Okay.
Go ahead and share the other slide, the other monitor. Stop share.
Oh, I'm sorry.
Okay.
Are you? Mm-hmm.
So now share screen and double click on the PowerPoint.
Okay.
That's the presenter mode side of things. So stop share and it's the other monitor that you want to choose. If you just click on the PowerPoint that's full screen,
Yeah, what I did.
Presentation mode.
That's what I've been doing.
Thank you.
Okay, good. Well, if that works, that's great. And I have some questions also. I'm going to see if I can't really see the chat, but I'm going to ask Troy to help me out with that. So I have some questions as they come up. Please put your answers in the chat. And just kind of a little poll audience type of stuff to see how things are going. So I'm going to talk about when to cool, but doing this, I also have to talk about who we're going to cool. So okay. So first question, randomized control trials have shown benefit for which targeted temperature management in which population, in which of these following populations? Okay, so which of these have had randomized controlled trials supporting the use of targeted temperature management? And I will tell you, you can select more than one. Go ahead and put your answers in the chat right now. I'll give you guys a couple of seconds. Okay. Any winners there, Troy?
I'm looking it up right now. We have one of them that shows, let's see, I'm getting some direct messages here. Let's see,
Okay.
2 and 3.
Okay.
If everyone could just post to everyone so we can all see them, that'd be great. So go ahead and post your questions to everyone and your answers to this poll?
So for the folks that put in 1 and 2, that is correct. Unfortunately, there's a bunch of nopes here. So we have a lot of negative trials. You know, not for lack of trying, people have looked at TBI quite a bit in NABISH 1, NABISH 2, which are adults, and PEDS TBI, Eurotherm, which more recently came out looking at patients with elevated ICP in the context of TBI. This study actually suggested perhaps patients might do even worse in the hypothermia group of this particular study. ICTAS 2 was an ischemic stroke with IVTPA. This was stopped early, but it was a negative trial. And then IHAS was an intracranial aneurysm surgery trial. I'm just showing you the big randomized ones. So, you know, and I think Kiwon's going to talk a little bit more about ICP management and TBI, but where we do have great data is for cardiac arrest. So these initial trials came out in 2002. These were really the seminal articles. This is the HACA trial conducted in Europe, and then this is the Australian counterpart trial. And both of these were in VFib or pulseless VTAC or types of arrest. Some of them were in hospital in the HACA trial, but the vast majority, over 90%, were out of hospital arrest. More recently, we have the Hyperion trial. This came out in 2019. And this actually was looking at non-shockable rhythms, so PEA and asystole. And this did find a benefit to targeted temperature management to 33 versus the control group of 37. Now, how big of a problem is cardiac arrest? This is where we have most of our data. So I just want to see how many people have cardiac arrest in the US each year. Okay, choices are 100,000, 250,000, 600,000, and 1 million.
All right. Looks like 250, 600,000. So 2 and 3 are the winners.
So 600,000 is the most recent data we have. And we used to think that most of these were out of hospital arrest, but we have better data that just came out this year in circulation. So it's almost a split between in-hospital and out-of-hospital cardiac arrest. And unfortunately, the survival rates are still low. So, you know, we're only looking at 10 to 15% of people surviving their initial arrest. And those that do make it to the hospital, 52% of those die. So it's a big problem, a lot of people affected, and, you know, outcomes are still pretty poor. So we really need to get aggressive on the therapies we know do work for these folks. So how long have we been using therapeutic hypothermia? 1974, 2002, 1907, 1955.
Wait for a couple of these to come in. Three, 1907.
Oh, okay, that's interesting. Actually, we're going to go with 1955. Stephan showed this picture before. This is really one of the first documented or well-documented uses of hypothermia. This is in an operating room at the NIH in 1955. You can see they're dumping ice into this. I have no idea how they operate on the floor, and I hope these are not wires. I don't know what these things are coming out of this water bath. But needless to say, it had been used quite a long time ago. And this is actually, you know, I think one of Stephan's heroes, Peter Safar from Pittsburgh. And you can see this is 1964 publication. And here he's kind of going through what we do for CPR, which is, you know, ABCs, kind of like what you're used to. It's a little bit funny to see how little things have changed, honestly. And then we have the drugs, epinephrine and bicarb. We don't have that many more options beyond these today. Defibrillation, giving them fluids, and then bam, down here we have hypothermia. And this is blurry, so you know, what it says is start within 20 minutes if no signs of CNS recovery. Okay, this is 1964. Already people are really kind of promoting this at this window of time. Things kind of fell off the map again until 2002, but at the moment, Peter Safar was really prescient. Start soon and be aggressive. Now, what is no sign of neurologic recovery, i.e. how bad do you have to be neurologically to be cooled? Now, I want to really bring this up because this comes up, it came up for me like last week with a fellow in the MICU, comes up not infrequently. What is a trigger? Okay. Would you cool someone who is not alert and oriented ×3? Someone who is not command following, not localizing to painful stimuli, or is not withdrawing to painful stimuli? Which of these are your trigger post cardiac arrest to start targeted temperature management?
I'm going to wait till somebody's not too shy, so hang tight. Okay, 2 and 3.
Okay, the answer is 2. Okay, and the 2020 AHA guidelines for CPR came out. Here's the take-home messages. If you open this up, 10 take-home messages. Here we go, number 8. Boom, prompt initiation of targeted temperature management for patients who do not follow commands after ROSC. Okay, so that's our threshold. I've seen people consult me a week after someone arrests. Oh, I didn't cool them because they were kind of moving around. I'm like, were they following commands? No, but they didn't seem that bad. Okay, well now they're still comatose a week later. You didn't cool them, and I have to talk to the family in a circumstance that for me is uncomfortable. So I want you guys to remember this. The threshold is just no command following. So unless they're awake and, interactive with you, you should really be considering targeted temperature management. All right. So how soon do you start? Peter Stafar is saying 20 minutes after arrest. Well, what do we know from the data? All right. So this is a paper from 2001. And so you can see these are people that weren't cooled, all right? So this is before the 2002 HACA and Australian trials came out and really revved things up. So over the first 48 hours, you can see the circles are the people that had good functional recovery, and the triangles are the ones who did not. And, over these first 48 hours, the triangle people are cooking more so than the people that did well. And in fact, there was a 2-fold risk of poor neurologic outcome for each 1 degree increase in temperature over 37 during the first 48 hours. So small differences matter. So there's a lot we can do for these patients. Now, how fast should we start? So we decided probably at least monitor, taking care of fever should be a priority. How soon should we get started? So next question is, during the code with intranasal cooling, in the ambulance with cold saline infusion, post code as soon as I can hook the patient to a device, within 6 hours of cardiac arrest, or within 12 hours of cardiac arrest.
We have someone that put in 2. Still waiting on some others. A 4. So 2 and 4 and another 2.
Okay. So I'm actually going to make the case for you guys that it's number 3. You wouldn't be
and
wrong.
2 3s. They just came in.
Okay. So 6 hours is the time frame they used in the trials. This is another thing I get a lot from the residents. But I have 6 hours to start. What's the rush? Let me just let this person sit around for a while. When I get around to it, I'll go put the device on. That's really not what we want. I think I'll show you in a second that, the sooner you can do this, the better. And then there's a couple trials for number 1 and 2 that suggest that you really don't have to kill yourself. And in fact, number 2 might be a little bit harmful. And I'll show you that shortly. So what happens if you wait around, and say, well, I got 6 hours, or I'll get around to it after I sign out or whatever? Well, the delays are costly. Okay. So every 5-minute delay to initiating targeted temperature management increases your odds of poor long-term neuro outcomes by 8%. So that's a big cost. If you want to look at death, you have a 20% increased risk of death for every hour you delay initiation of cooling. And here's another kind of graphic here. Poor outcome in the triangles, good in the little dark squares. And, so the people that got colder faster and stayed cooler had better neurologic outcomes than those who did not. So time is of the essence. And if you look at the different trials, so this is the HACA trial. So this was, 2002, very early on. They start cooling relatively quickly, but it took them a while to get to target. This says 6 to 8 hours if you're considering 32 to 34. If you're considering 33, it really took them like 12 hours. And, they were using kind of basic stuff here. They had a cold air plus ice. So kind of like blowing air over these folks. It worked, but it took a long time. Nonetheless, despite their inefficiencies, they really saw a significant effect of hypothermia versus normothermia. And the number needed to treat to prevent 1 death was 7. So this was a really robust, game-changing type of finding in this paper. In the sister article that came out at the same time, this is in Australia, a smaller study, they actually started cooling people in the field. They cooled for 12 hours as compared to HACA, which was 24, but they used all kinds of stuff, ice packs, whatever they had. It took them about 120 minutes to get to target temperature. And then they rewarmed people after 18 hours. And they actually did not so bad. By the time they got to the ICU, I don't know what time that was, presumably before 6 hours, these patients were at their target range of 33. And in more recent studies, so this is TTM1, or the first targeted temperature management trial, where they basically were looking at 2 different targets. It's almost 1,000 patients, and most of them were out of hospital and they could have any rhythm. Then they randomized to 36 versus 33. And they had to be randomized within 240 minutes, which is 6 hours from ROSC. They used a variety of different cooling methods were allowed, but most people really got surface cooling or intravascular cooling. They cooled them for 28 hours in this study, then rewarmed them at 0.5 degrees an hour. And interestingly, this is something people forget, is that they actually locked these patients at 37.5 for 72 hours after the arrest. Okay, so they actually, not only did they cool them for a period of time, but then they left them in a normothermic state using a device for 72 hours. So that's a little bit different than some of the other studies. Now, despite the fact that they use intravascular and surface cooling, it still took them about 8 hours to get to 33. If you're looking at 34, they got there in a couple hours. So, depending on what you consider to be therapeutic, which most people would probably say between 32 and 34, they did it pretty fast here and in the active cooling group. Now, I just want to say one other thing about TTM, is that this 36 group was not just, let's leave them alone and walk away, and we're only going to put a cooling device on the 33 group. Both of these groups had devices on them. And this I see a lot. Some people are like, well, the patient was already, 36 or 35.5. So I didn't put anything on them. I just left them. They were already hypothermic. Well, maybe at the moment you were with them, but 5-10 minutes later, they could be 39 degrees. That's really not what is meant by this TTM trial. This is really aggressive normothermia versus aggressive hypothermia. And I think people have to remember that. And then it was sustained for 72 hours after initiation. So, I think that message gets lost for some folks. Now, here's a Hyperion trial. This is 581 people with asystole or PEA, 33 versus 37 for 24 hours. Again, a lot of different cooling devices. They rewarm slowly. They were pretty quick. Median time to initiation, 16 minutes. That is fast from randomization. And they got to 34 in like 2 hours. And, it took them like 8 hours though to get to 33, depending on what you think is the most important area. Their target temperature was 33. So it was not as fast as probably they would have wanted. Nonetheless, it's a positive trial too, which is great. Their primary outcome was cerebral performance score of 1 or 2, which is an excellent recovery at 90 days. And you can see the hypothermia group had better good recoveries than the normothermia group. Now this gray area is dead. So still 82-84% of people are dying, which is, we have a lot of work yet to do in cardiac arrest, but at least we have something that does offer a little bit of hope here. Is there such thing as too soon? Okay, so the this is the intranasal during cooling that they did during the actual arrest. This is a princess trial. And they basically were pretty good. They got to their target temperature in 105 minutes in the intra-arrest intensive group versus about 3 hours in the control group, which is certainly a bit slower than some of the other studies. But they really didn't see any difference, unfortunately, for their primary outcomes. Even across different groups, you can see all of the confidence intervals seem to cross 1 here. When they did look at subgroups, so here's the primary, this is all the patients here, and there's no difference between their CPC scores. When they did look at the shockable rhythm people, they did seem to do better with intra-arrest cooling. So somebody might say, I'm gonna start super early in my shockable people based on this secondary analysis. And that's probably not wrong, but it may not also make that much difference. We have to remember, you have to look at the primary analysis, and the secondary analyses are not as reliable in these randomized trials. Here is cooling in the ambulance. So this was also from the Australian groups. They had 234 people with VFib arrest, and they cooled them with 2 liters of cold lactated ringers. And the comparison group was people that got cooled when they got to the hospital. So the cold saline group was colder when they arrived, but there was no difference in outcomes in this particular study. In 2013, another study came out, 583 VFib patients and 776 non-shockable rhythm patients. And pre-hospital, they gave them 2 liters of saline versus regular cooling when they arrived. And they did cool them faster, as you might imagine, but there was no difference in survival or neurologic outcomes in these patients. And significantly higher number of patients rearrested who were cooled in the field, and there was more pulmonary edema for those who were cooled in the field. So based on this, pre-hospital cooling is no longer recommended by the AHA. So how long do we cool folks? Well, at least 24 hours is what we think, okay? The trials cooled anywhere from 8 hours to 28 hours. The Nielsen study I talked about already locked people at 37.5 for 72 hours after they were either cooled to 33 or to 36. Right now, there's an adaptive trial going on where everybody's going to be cooled to 33 Celsius, but looking at different durations, either between 6 hours or 72 hours. And the interest there, of course, is, as Stephan had kind of alluded to in his talk about the complications you can face with hypothermia. Maybe we don't need to expose people to as many complications. Maybe we can garner even more benefit than we're already seeing with these folks. And then in terms of rewarming, we usually go on the gentle side, 0.25 to 0.5 degrees Celsius per hour. And that's largely to avoid a couple of complications that can happen with rewarming. First, we're always worried about cerebral edema. Hypoxic brain injury certainly can cause cerebral edema. If you warm someone up too quickly, you could really have rebound or exacerbate this brain swelling, which would obviously be counterproductive. Additionally, when you rewarm somebody, they peripherally vasodilate. You can have drops in blood pressure. And so in order to avoid any major hypotensive episodes, you really want to be delicate. And most studies rewarmed at this rate. There is a study that I came across that is now rewarming at 0.33 degrees Celsius. That's TTM2, and I'll show you that in just a second. So when would you not cool somebody? I'm going to poll you guys again. So here's a patient you can see they got everything here. Every single pressor you can imagine. I see that one is dopamine, but there's levofed, vasopressin, you got a lot of stuff going on here. Would you cool this patient post-cardiac arrest?
Dr. Frontera, while we're waiting for that answers in chat, I just want to recognize the time. So I believe you've got a bit more content as well. So just want to
I'm almost done.
aware of that.
Great. A couple of number ones and number 3.
Okay. All right. Aggressive. So I would say personally, I would say yes, but I would do 36. I would do induced normothermia. The issue with a lot of pressors, if you're going to do surface cooling, for example, is you can really get skin necrosis in that context. If you want to make some kind of case for intravascular cooling, I suppose you could, but I think the safe thing to do for most of these folks would be to go to 36C. Unfortunately, what we see a lot is people don't cool them at all. And that is probably counterproductive. You're not going to see all the complications in regards to skin necrosis, coagulopathy, et cetera, that with 36 as you might with 33. How about this guy? Here's a guy, rampant DIC, he's bleeding all over the place from every orifice. Would you cool this guy post-cardiac arrest?
Survey says yes at 36, no.
Okay.
Another no.
All right, I'm going to make the argument again for this person. Go for the 36. Again, you're not going to make them more coagulopathic, and they may have benefited, at least based on the Nielsen trial. The other thing I will say is sometimes this came up not 2 weeks ago, patient that had a TBI and arrested. Now, just because I showed you that the data for TBI itself is not great, the data for a cardiac arrest still is, and you shouldn't worry about a hypothetical coagulopathy in a TBI patient. You should still consider cooling them and treating them the cardiac arrest as a primary insult, in which case you could go to 33. And if you're really skittish or some of your clinicians are a little hesitant, at least do 36. Here's the last one. Here is somebody with going into sustained VTAC. Would you cool this patient? And I'm just going to jump to my answer here of, yeah, I'm going to do 36 again. So when you get very hypothermic down to 33, 32, or 34, arrhythmias can be refractory. So you would have to, if you're already at 33, you have to rewarm this patient, but then you could stop at 36 and leave them there, okay? Because you're not going to have as many arrhythmia problems at this normothermic temperature. Okay, so just to summarize, here's the AHI guidelines from 2020 that just came out. So TTM for adults who do not follow commands after ROSC, out of hospital, any rhythm. Same thing, in hospital, non-shockable. In hospital with initial shockable is a little bit less strong, only because there are very few patients in the 2002 studies that were actually in hospital cardiac arrest. But, you know, in hospital, out of hospital, any rhythm, we cool them. There we go. They say select between 32 and 36, maintain for at least 24 hours. And it's reasonable to prevent fever after they're finished with TTM. And then they don't recommend using cold saline because of the one study that I showed you from Kim in 2013. TTM2 is coming soon, any day now. This is 33 versus 37.5. Both of these people have devices. So the device starts if you're above 37.8 in this group. And so we should have this data coming soon. And I want to just, I came across this, I feel like this is a fascinating story. But this is from 1650 in Oxford. Here is this woman, Anne Green, and she got pregnant out of wedlock, so they had to kill her, and they hang her. And what they did there was, you know, the protocol is I'm going to hang you for 30 minutes, then I'm going to take your body and I got to send it over to Oxford Medical School because all the med students had to do 2 cadaver dissections to graduate. And so they got them from the hangings. So it's December, so it's cold, right? And they hang her. They take her off, put her in the coffin, ship her over to the med school. They open the coffin and lo and behold, she's breathing. So they're like, they reverse course and decide to resuscitate her. And here is their protocol. So first they pour hot liquor down her throat. Then they administer a tobacco smoke enema. I have no idea how that is executed. They drain about 5 ounces of blood, tickle her throat with a feather, rub her body vigorously. This is all her rewarming tactics. And then they place her in bed next to a warm woman. Yeah, I don't think this would pass the IRB these days, but it turns out it worked for her. After 12 hours, she started speaking. 24 hours, she was answering questions freely. And then 48 hours later, things are great. She's back to normal, except she doesn't remember that whole execution business, luckily for her. Anyway, we've come a long way since 1650. And I hope that I have some time for questions. I'm not sure. I'm sorry I went over because my technical issues in the beginning, but I will end there and turn it over to Kiwon.
Let me, if I could, just really quickly, thank you, Dr. Frontera. And I do want to pose one question that's here. There's a lot of data for cooling sudden cardiac arrest patients. What about just preventing fever for a true neuro patient? Should we prevent fever for any disease state, i.e. stroke, mild TBI, status epilepticus, etc.?
Yeah, I mean, I think there's really not much in the way of randomized controlled trials for fever prevention that so I was really sticking to that. But there's a lot of other data about fever control in neurological patients and how important it is. And Stephan has really been one of the people that's published most of that. You have an expert right here on this Zoom meeting.
There is a trial in process now called Intrepid,
Yes.
which is looking at the question of very early sort of feed locked to normothermia for SAH, ICH, and ischemic stroke, the sicker side, obviously, where you're anticipating a longer ICU stay. So we'll see. We'll have that data. It may still be a few years away, but.
And then just maybe just a short one. Might not require a short answer, but what's the benefit of prolonged hyperthermia? So I'm assuming what's the benefit to the patient, if there is any?
Of prolonged hypothermia?
Hyper. So what's the benefit of fever? Should we let just the patients be febrile?
I have a hard time seeing the upside of being febrile. I think there's probably some, exquisitely complex immunological arguments about what happens when you have a fever that may produce a benefit. I'm wondering if the person was really meant to say hypothermia. Yeah, I think that we don't have that much data beyond 28 hours, honestly, from randomized trials for hypothermia.
Can I chime in?
You get into complications at that point. So yes, go ahead, Stephan.
Yeah, I just want to point out to the various people watching, TTM is really only for neuro, right? The other units see plenty of fevers and medical ICUs, SICU and whatever. There's no real imperative to treat the fevers in somebody who has a bacterial infection and a fever, as long as they have no, active ongoing brain injury. And there's that whole, old saying, feed a fever, starve a cold, and maybe that fever helps the immune system fight off an infection. But do understand that before we started doing the TTM, there were many, many, many studies looking at the relationship of body temperature and outcome in all forms of stroke and TBI. All of them have found the hotter you are, the worse you do. So, that's a big reason for in the neuro ICU with the acutely brain injured patients, why many neurointensivists are just not going to sit there and let their patients be 102 degrees.
Excellent. Thank you for that. Appreciate it. Dr. Frontera, fantastic. We're very grateful for your time. Thank you for that wonderful talk. We're going to round it up here with the cleanup hitter, Dr. Kiwon Lee. He's a professor of neurology at Rutgers, the State University of New Jersey, Robert Wood Johnson Medical Center, and chief of neurology at Robert Wood Johnson University Hospital. Dr. Lee also serves as the director of Robert Wood Johnson Comprehensive Stroke Center, division chief of stroke and critical care, and director of neuroscience intensive care unit. He's authored over 230 peer-reviewed abstract articles, book chapters, clinical research publications, and 2 neurocritical care textbooks. Dr. Lee, thank you so much for joining us. The time is yours.
Okay, let's see. Can everyone see it?
Perfect.
Thank you. Thank you, Troy, for that introduction. And it's an honor to be at the same virtual podium with luminaries of our field, Dr. Frontera and Dr. Mayer. And I've been thinking, and you guys been hearing how to do it, when to do it. But you know what? In my mind, you need to be convinced, first of all, why you bother to do it. So thanks for Troy for giving me this talk, why to cool, which I think is tougher, more fundamental question, and I'll try to tackle it with you. So a few years ago, there's an international hypothermia symposium, almost 10 years ago back in Japan. When I went there, I said, everything about cooling is so cool. This is when Dr. Mayer was conquering the entire universe with his book, how hypothermia back then, no one called it TTM. Back then it was hypo, cooling, cool, lower, lower. It was all about hypothermia, and it seemed as if you lower it, everyone will have magical outcome. Back then, it seemed that way. Why? Because there was this article study that Dr. Frontera shared. People had a cardiac arrest, they're comatose, they woke up, they did better. It was shown in a class 1 level of evidence. In addition, the hypothermia seemed to be somewhat beneficial for those who had a terrible encephalopathic pictures in neonates due to hypoxic ischemic injury. In scientific, particularly in animal models, there seem to be many levels of evidence, and one of which I found fascinating is this matrix metallopeptidase -9, which has been associated with numerous pathological processes. And if you reduce MNP9, and again, it's been seen in animal models, that you may attenuate the blood-brain barrier disruption, which would be a good thing in an inflammation. Then you keep hearing these anecdotes and news around the world, how little kids are found at the bottom of the icy pond, and how can it be possible? You know, it must be the cold temperature did it. Then after the Haka trial, everybody is thinking, well, how long you've all done, I'm assuming everyone here has been involved in some degree of intensive care medicine. So last time, just think back, last time you were running a code, whether you're doing a CPR yourself or whether you're running it. Remember, like the last time you're running it, the most important question after a while is, how long am I gonna go for, right? At least it is for me. You know, especially young people, I don't wanna give up. Like when are you supposed to stop? Why is that an important question? Because people tend to think that hypothermia is protecting the brain. So, you know, in the era of hypothermia, I think that lower temperature may buy some time. So maybe you should do longer. Meaning even after, what I meant by that is even if you had a prolonged CPR, if you cool them, maybe you'll have a chance to wake up. So there seems to be some favorable responses in hypothermia. In out-of-hospital cardiac arrest, we know, and you heard, and I agree, Dr. Frontera said that you are supposed to have TTM 33 or 36, which is lower than normal body temperature. So I'll just say cool. You're supposed to cool them until the data tells you that you don't need to cool, meaning you can only keep them at a normal temperature, which would be TTM2. Until then, the standard of care is you're supposed to cool them, either 33 or 36. If you're dealing with a hemodynamic instability, as Dr. Frontera already mentioned, 36 may be better. And I think that's the current standard, but I think the question, though, that comes up all the time is, as Dr. Mayer mentioned, you know, if you have normal brain, who cares if you have a little fever here and there because you got some UTI? Whatever, treat the UTI. Fever wouldn't do any damage to your brain in the long run, so who cares? Well, he's absolutely right. So then what about other neuros? What if you have malignant cerebral edema? What if you have ICH, SAH, Metabolic demand for oxygen is high, severe TBI. What about heart attack? Could you reduce the myocardial infarction tissue volume if you cool them? Well, some people think that, and especially those hypothermia lovers continue to believe that if you have a heart attack and you give them cold saline, and maybe you will reduce the size of permanent myocardial injury. Well, so far, the data shows that it may be feasible and it's doable, but we don't know whether it'll actually improve long-term functional outcome. A couple of studies here and there did show reduction in heart failure incidences. And that sort of is the cardiac literature. Dr. Frontera again mentioned these different degrees of TTM. Quite frankly, I don't know about Jen and Stephan, but until 2013, I was a strong fan also. I still am, but I'm a fan of modulation, not necessarily lower the better, which used to be the sort of the theme in the past. When this Nielsen study came out, this is problematic. First of all, I agree with Jen in that 36 doesn't mean neglect your patient. And a lot of people and the readers of this paper took home a wrong message. Well, 36 is essentially nothing, so I'm just gonna not bother. I told you hypothermia doesn't work. Some doctors have actually said that. But again, as Jen mentions, that's a wrong take-home message. 36 does not mean neglect your patient. It does not mean nothing is the same as hypothermia. It means you need to modulate it and keep it at that level. What bothered me though is that 36 really is almost normal temperature. And I did not think this would be no difference in outcome, but the fact of the matter was that there was absolutely no difference in terms of outcome, long-term outcome, whether it's 33 or 36, which makes you wonder, does the lower the better because it makes sense scientifically? Were we all wrong? Maybe. And we may be even more wrong when 37.5 shows the exact same thing as 33. There's a good chance of that maybe coming out, that there's absolutely no difference between 37.5 and 33. Then I'm gonna be, disappointed second time around. And I think we will stop saying lower the better. And maybe it's just a reduction, avoidance of fever, which we all kind of tend to believe that is bad. So I'll just skip over all these. This is a picture of one of my patients from Texas, where more number of people carry guns around. And when you have left to right, literally transecting the brain like that, guess what? They don't do well. But this is my favorite study that I quote a lot is the Eurotherm 3235. Again, why do I like this study? Because a lot of people took home wrong message. This basically was a TBI patients having lots of ICP problem. They randomized, they compare hypothermia defined by 32, 33, 34-ish, the typical good amount of hypothermia versus just a regular standard therapy. And they randomized hundreds of patients and everyone got stage 1, which is sort of universal. You gotta intubate them because they can't protect their airway. They all have bad TBI, head of the bed elevated, MAPS reasonable so that you'll have decent CPP. Yeah, put EVD if you need to, blah, blah, blah. That's all good. But stage 2, people are randomized to osmotic therapy, so mannitol hypertonic saline, or hypothermia. So drop the temperature down to 32, 33, and see if that makes any difference. Well, it showed that 6 months later, those who got hypothermia, we're talking 32 to 34, they actually had worse outcomes. So people are saying same thing with the Nielsen study. Oh my gosh, you cool them, you got TBI, you're cooling TBI patients, you're gonna kill more patients. It's worse, you're actually harming them. Well, I think that the critiques and the lessons from that Eurotherm 30 to 35 is the following. Number one, cooling people as soon as you're done intubating them is not how we utilize CTM or hypothermia for severe ICP crisis patients due to severe TBI. At least that's not how I do it, and that's not what I wrote in my book. You're not supposed to just cool them after you intubate them. Not really. You're supposed to sedate them and maximally sedate them so no one is actually turning red. I mean, things that you need to do before, there are things you need to do before thinking about dropping the temperature to 32. And quite frankly, osmotic therapy comes before that, in my mind. But in this trial, they jumped straight to hypothermia and they compared that with osmotic agents. Problem number one, in my mind. Problem number two, they allowed the hypothermia group to jump over to osmotic agents, meaning if you cool them as the first thing to do, and then later on, you may say, I'm going to give mannitol anyway. So the whole design and how it turned out to be was a little bit more complex and dirty, if you will, and I don't really like it. And I think that we need to remember that is not, that the way they randomize is not exactly how we do things, number one. And number two, I do think that those of us, some people around the world who think that if you lower the body temperature and everything's gonna be perfect, well, you're wrong. Because if that is true, then the group that got hypothermia with a severe ICP, they should have done better, not worse. But this study clearly showed they actually did worse. So it's a wake-up call for those who believed in hypothermia too much, that you can actually harm people. One more comment before I go to my conclusion slide. I think that we want to save the brain and obviously reduce the brain injury, and we want to wake these comatose patients up. But you also want to be a good intensivist, a good doctor, and pay attention to the hemodynamic profile, and you certainly do not want them to have cardiac arrest again. And so I do think that we need to be a good general doctor in addition to try to be a good brain doctor. So, I just want to show you this young patient of mine. As you can see, there's a nasty, really, really malignant right MCA territory, 27-year-old. We don't need to talk about the etiology, although that's actually an interesting topic, right? 27-year-old shouldn't be having a large stroke like this. But as you can see, as the brain is tight, the right MCA is pretty angry. Would you do a hemicraniectomy, after intubation? And this is like early versus late, basically the standard is that you're supposed to do early hemicraniectomy, especially if you're so young and etc. But actually I didn't. Just want to show you the anecdotal experience here. I did optimized the osmotic, the serum sodium target has been raised, and I actually did a mild hypothermia, so 36 degrees, and patient did not herniate and did actually okay. So I just want to summarize by showing you, I think the future of therapeutic hypothermia, which used to be the title, really is a TTM. And for out-of-hospital cardiac arrest, 33 versus 37.5 is ongoing. We will get the results soon. And if that's negative, I think the hypothermia for cardiac arrest is going to go away, but it's more like a prevention or treatment of fever is going to be the more appropriate term. But until then, as Jen mentioned, you're supposed to cool them, either 33 or 36. If they're kind of not really stable, hypotension, for example, severe electrolyte disturbances, coagulopathic, sepsis, septic shock, etc. Exactly the same point that Dr. Frontera made earlier, 36 might be safer. Ischemic stroke, I use hypothermia. I've published a couple of journals, articles in stroke for malignant cerebral edema. And it seems to be helpful, but I don't have a class 1 level of evidence that if you have a large angry ischemic stroke, you cool them, they'll be better off long-term. That we don't have long-term outcome data on that. Subarachnoid, I use cooling a lot, and it is for the ICP and CPP optimization and optimizing the PbTO2. Because I do think that ICP crisis is really, really bad in SAH, worse than ICH, worse than any stroke, ischemic stroke, SAH, high-grade SAH. It's essentially the battle against the ICP early on anyway. I do think that hypothermia might be helpful. For TBI, once again, I just want to read you this quote from Hypothermia Temperature Management article. The best performed randomized studies showed no improvement in outcome by hypothermia. Some even indicated worse outcome. True. TBI patients may suffer from hypothermia-induced pulmonary and coagulation side effects. True. From vasopressors when re-establishing the hypothermia-induced lower blood pressure, rebound increase in intracranial pressure, the difference between body temperature and temperature set by the biological thermostat may cause stress. These mechanisms may counteract neuroprotective effects of therapeutic hypothermia in the setting of severe TBI. I totally agree. The authors conclude that we still lack scientific support as a first-tier therapy for the use of therapeutic hypothermia in severe TBI for adults and children, but it may still be an option as a second-tier therapy for refractory intracranial hypertension. And I think that's a very eloquent and scientifically appropriate, accurate statement. And that's exactly what I do. So again, I want to end why to cool, how temperature modulation reduces brain injury. It might reduce the brain injury, it might not, but we do have some benefits, clearly indirect benefits, reduction in ICP in neuro patients, reduction in ICU stay. These are all indirect benefits. And while we don't have class 1 evidence for neuro patients, just for the neuro, there are some useful indications. And for the cardiac arrest, once again, until 37.5 comes, TTM2 results become available, you are supposed to do 33 or 36 if they're out of hospital cardiac arrest. And thank you for your attention.
Awesome. Thank you, Dr. Lee. Appreciate that. A couple of questions here. Do you subscribe to targeted temperature management as a dosage? And then the follow-up to that is, how do you decide what temperature you will choose for a particular patient?
Which patient? It depends. Thanks for the question. So I assume you're asking twofold questions. So you can ask me the same question for a cardiac arrest comatose patient, or you can ask me for someone who never had a cardiac arrest but dealing with a bad brain injury. So for the cardiac arrest, we already talked about this a few times. You can choose 33 or 36. There is no difference. That's the TTM1 level of evidence. You can choose either one, and either is fine. But you need to remember that 36 might be gentler. It might be safer if patient is having hemodynamic instability, i.e. hypotension. You're already on one pressor. Patient is coagulopathic. That's my timer for 20 minutes. That's the cardiac arrest. Now for neuro, meaning stroke patient, herniating, high-grade subarach, massive ICH, etc., severe TBI with refractory ICP crisis. Which one do I pick? And once I answer, I'm gonna open it up to Dr. Mayer and Dr. Frontera, what level of temperature they use for refractory ICP due to TBI. Which one do I use? I actually use 33 for severe TBI, refractory ICP. And the key here is refractory. And the reason why I think that, again, this is just a personal subjective opinion. It's not class 1 evidence, okay? I think that if you're having a refractory ICP crisis due to horrible cerebral edema in a transecting the brain gunshot wound, 36 ain't gonna cut it. It's 36 is close to normal temperature. I don't believe it'll produce enough reduction in CBF. If you ask me what is the mechanism as to how hypothermia reduces ICP, in my mind, a lot of people have different theories. And I'm sure everybody's right. Some say it's the metabolic demand, the cellular oxygen desirability. Well, I think it's more for the flow, because when you cool somebody, your flow goes down, your heart rate goes down, your BP goes down, your blood volume being delivered goes down, your cardiac output goes down. So your CBF goes down, and CBF is volume per time. When volume goes down, pressure goes down. Why? Because volume is the best friend of the pressure. So if you reduce cerebral blood volume, you're gonna reduce ICP. Let's see what Dr. Mayer does for a severe ICP. What temperature level do you choose?
Severe ICP, I've actually been doing a kind of a stepwise approach. So I would initially target 35.5 and see how well that works, and then push it down to 33 if, you know, if it's not getting us where we want to do.
Okay, Jen?
Yeah, so I think like you guys, I also do stepwise, right? Starting off with, you know, EVD, surgical intervention, osmotherapy, sedation, you know, head of bed, midline, elevated, and then, you know, if it's really refractory, then I would probably go right to 33 or 34 if I got to that point.
Yeah.
I probably am going to go big or go home at that point if I've hit that level of refractory ICP, which we all have. We've all done this. We've all used hypothermia for these refractory patients, you know. So.
Well, Jen and I are a couple of years younger than Stephan, which means, you know, it's likely that we're more aggressive.
Come on, you are not that.
Any other questions from the audience? I would love to answer if you have any.
Yeah, another one here. There's no class 1 recommendation for TTM for high ICP, but if we don't control temperature and prevent fever greater than 38.3, what is the potential impact to the patient?
Yeah, so I think, thanks for the question. I think that there is a big debate as to what does the different level of hypothermia really do to brain injury, but there's much less debate, much less debate, what badness of fever would do to the injured brain. And we all think that bad brain injury and high fever are just absolute no-no. We think that when it comes to, and it's been shown in animal models in ischemic stroke, I think the best, that the infarct size will increase. So if you want your stroke patients to have a bigger stroke, let them be very hyperthermic, and I promise you their infarct size may get bigger.
Excellent. Dr. Frontera, Dr. Mayer, do you have anything else you want to add onto this one before we move to the next phase here?
I was just trying to see if I could pull up one of Stephan's articles where you have those nice curves showing what happens when you're cooking hot in terms of your neurological outcomes as compared to when you're normothermic. And, you know, I remember you have a great video from ages past of somebody that you was not command following and then started following commands once the fever was controlled. And frankly, we've all seen this. I'm sure you guys have seen it too, that fever is one of the major reasons you can see declines in neurological exams. So right before your eyes, if you control the fever, you can improve how these people are doing. So clearly there's something deleterious there if it's obvious enough for you to capture on a neurological exam. So.
Yeah, this was a guy who was completely comatose, but very febrile. we corrected his body temperature with an advanced cooling device, and he literally woke up and was following commands. And then to prove the point, we turned it off. His temperature went back up to 40 centigrade, and he became stone cold comatose again. So it
Stone
would
hot comatose.
stone hot comatose. But it would appear that fever actually interferes, in addition to having deleterious effects on cellular injury, can also interfere with consciousness mechanisms. And the implications can be profound, because if you're taking care of a ventilated patient with a huge subdural and you haven't seen them follow a command in a week, then you're going to start to talk to the family about, well, the trach and peg, but we don't expect him to do well, right? And you honestly believe he wouldn't do well because he hasn't followed commands for you. He remains comatose, right? That guy's more likely to have life support withdrawn. If you do things to help promote consciousness and brain function, you turn off sedation and treat favors, and then you're sitting down with the wife and saying, hey, no, 2 fingers, thumbs up, you know, he's starting on the road to recovery. So it can literally have life and death implications.
Excellent. Thank you. Again, Dr. Lee, thank you for that. Really appreciate hearing your talk there. Let me again thank our panel for taking the time with us. And just to take away from me, I know I wasn't in one of the chat rooms, but I had several sort of aha moments as I've listened to each of the speakers. I wrote a couple of them down. One of them was mentioned early on by, I believe, Dr. Mayer. Anytime you see shivering, that means your system is working. So you remember he mentioned early on some of those more mom and pop devices, the antiquated water blankets, and how they never reached target and therefore never started to shiver. So that was a moment for me that I thought was really important. Another one, if your patient does not follow commands, that triggers the use of temperature management. And I thought that was also very insightful. As well as, while we don't have a lot of data that suggest we should, or that cooling by itself will create a positive neurological outcome, we do know based on data that not preventing fever can lead to severe problems. So there is definitely an argument to be made for implementing temperature management regardless of the disease state. Now with that, we'll go to Dr. Mayer first, then Dr. Frontera, then Dr. Lee. If you will, just sum it up for us in 1 minute. Dr. Mayer, you're on.
Oh man,
Buckle up.
Couple
minutes will be fine too.
Yeah, I guess this may seem unusual or something, because I'm not going to talk directly about TTM and the topics we discussed today. What I want to say is that if you do patient care, and if you take care of critically ill patients, neuro or otherwise, I encourage you to be curious, and I encourage you to try new things, to be innovative. Do not be afraid to push the envelope a little bit. Medicine is full of all kinds of rules and regulations and policies and practice guidelines and standards and everything else. And I get it, but do not let that squelch and squash your creativity, because a field like medicine will never advance or move or improve without people that are pushing the boundaries a little bit, trying new things, and just thinking all the time, what else could I be doing that could be a little bit better than the same old stuff I've been doing up until now?
Wonderful. Thank you. Dr. Frontera.
Okay, great. Thanks, Stephan. So I would just say there's 3 real pitfalls that, at least post-cardiac arrest, that people fall into, particularly trainees or people that maybe are general ICU or whatever. First is to think your patients doesn't need to be cooled because they're moving around. And you know, Troy mentioned the command following. Really think about that. I want people to be aggressive. Second is that, you know, if somebody has a theoretical complication or contraindication, like they're coagulopathic or they're septic or they're on pressors, think about 36, at least do something. And if you're gonna do 36, this is the last point, put a device on them. 36 does not mean nothing. It doesn't mean just leave them out, to do whatever they want to do. Put the device on them and lock them at that temperature. So all these things are, really be aggressive. And remember that, outcomes from cardiac arrest are really can be horrific, but we have a great opportunity here to use a technique that can really improve these people's outcomes. And I think we really owe it to our patients to be aggressive in that way. And I guess I'll shoot it over to Kiwon.
After listening to Dr. Mayer and Dr. Frontera, I feel like I'm in a medical school graduating, listening to the keynote philosophical, inspiring notes. And I totally respect that and agree with that. And for me, I would summarize that we will soon know what 33 versus 36 versus 37.5 for cardiac arrest patients gonna be. We'll soon know. Until then, and also beyond that, I think that when you're dealing, next time you see a patient with a massive cerebral edema and refractory ICP, know that hypothermia or reduction of body temperature can help you fight that, and you can actually use that as one of the second or third tiers after making sure that things that you're supposed to be doing, i.e. ICP, intubation, hemodynamic stabilization, sedation, and osmotic optimization, after all of that's been done, and you really don't feel like using pentobarbital and make patient look like brain dead for the 72 hours plus, that hypothermia may help you in that neuro patients, even if that patient is not a cardiac arrest patient.
Fantastic, thank you. Also, as I listened to each of you guys speak, I wrote down one other thing here, that TTM is an evolving therapy. And I expect we'll continue to see more data and more studies on this as time passes. And we're fortunate to have the 3 of you, Dr. Mayer, Lee, and Frontera, speak to us about this. And we look forward to learning from you more in the future. With that, we'll go ahead and wrap this up. Again, thank you all for joining. And I know there are many others who will be viewing this, the recorded session as well. So thank you all very much. Hope you have a wonderful evening. Goodbye.